information can be found in your Giddens book. Just going to kind of review with you briefly the objectives. This is loaded in the Canvas module. Our exemplars will be palliative care, death and dying. You have 8 objectives. The first one is we're going to identify the nurse's role when caring for clients who are experiencing loss, grief, or death. Number 2, we're going to describe the types of loss experienced throughout life. So when I say throughout life, we're going to talk about from infant all the way across the lifespan to elderly. So if you will, on Thursday, be sure to bring your maternal child book because we're going to be covering some of the care for the deceased infant or stillborn infant. Okay. Number 3, types of grief. And types of grief can be found in your Potter and Perry book. We're going to talk about one in particular, the Kubler-Ross. Are you all familiar with the stages of grief? Y'all remember that? Yeah. That's it. We're going to go over those. Number 4, describe characteristics of a person experiencing grief, what that individual may go through. Discuss variables that influences a person's response to grief. Develop a nursing care plan for the family experiencing loss and grief. Identify ways to collaborate with the family members and the interprofessional team to provide palliative care. So a big part of our discussion is going to be on palliative care versus hospice care. Describe interventions and symptom management for clients throughout life. What do we do for that individual as they're going through the death and dying process, and the family support? And discuss criteria for hospice. So what does it take to get on hospice? How do you qualify? I uploaded a document to modules just a little while ago that goes over a referral for hospice. So I think it's the last thing in the module. Be sure to click and review it. And describe the care of the body after death. Anybody with experience on post-mortem care in here? Okay, great. There's 2 examples in your book, one from Med-Surg and one from Potter and Perry. The Med-Surg one is kind of a short box, but the one in Potter and Perry has a little more detail. So I'm going to ask you to refer to both of those in terms of studying for your exam, okay? And we'll have a clinical simulation activity where we're going to do that on next week. Any questions before we get started? Yeah. We're going to the morgue. Y'all didn't get the memo? Somebody got it. All right. Yeah. Thursday. And you do need to be here, okay? No exceptions. So let's get started. Let's look at palliative care. And we just went over the objectives that we're going to cover for this concept. Again, we have 2 exemplars, and those include palliative care and death and dying. So CMS defines palliative care as a means for the patient and family-centered care that optimizes quality of life, anticipating, preventing, and treating suffering. And that's what we're going to look at. Taking care of the patient throughout the entire process while providing support to the family. Palliative care throughout the continuum of the illness involves addressing the physical, intellectual, emotional, social, and spiritual needs to facilitate patient autonomy, access to information, and freedom of choice. So we're going to support the patient throughout the entire process. We're going to honor their wishes in terms of whether or not they decide to stop eating or whether or not they want no medication, okay? We're going to talk about all of that next week. When we look at the definition, originally it was associated with end-of-life care or when curative treatments are no longer an option. And again, if we look at palliative care versus hospice, you'll be able to understand and differentiate the difference. Now it's used to promote quality of life throughout the pain and symptom management. We're going to look at the individual's functional status. And again, we're going to support the patient as well as the family. Do you all believe or feel like the patient's family needs support going through this process? Oftentimes, if it's a terminal illness, the individual is given 6 months or less to live, could that not affect the patient as well as the care providers or the initial family members? Yes, it can. How many of you have had any experience dealing with death and dying of a loved one that lasted for some time? I see quite a few of hands. So hopefully we'll get an opportunity to experience, share, and discuss some of the things you may have went through. When we look at the actual scope, palliative care and hospice care are a part of the continuum of care. And again, we're going to look at the difference between the two. You have a nice chart in your Med-Surg book that give you an exemplar of the difference between the two, with palliative care being at an earlier point in the illness trajectory and possibly continuing throughout the end of life. There is a need for palliative care across the lifespan, and that's for the infant. Think about those children or pediatric children that are born with some type of anomaly or may get diagnosed with a terminal illness like cancer or leukemia. So can you see or understand the need for palliative care across the lifespan? Yeah. Medicare hospice benefits will be available to patients when they receive a prognosis of life for 6 months or less. So anytime anyone is given that prognosis to live 6 months or less, Medicare hospice benefits are available for those patients. And your book does mention that. Some of the attributes and criteria is state-of-the-art, it's individualized, and this information is coming from 481, I think, in your Gibbs book. Again, we're going to be supporting the family as well as the caregivers, and there is an interdisciplinary team approach. When we say interdisciplinary, what does that mean?
Everybody works together.
Everybody's working together, and usually that's a team of who? The care provider, the social worker, case management, maybe dietitian, therapy. It could even be the chaplain, right? So a team, they're all working together. It's going to be a team approach. Other attributes include optimal assessment and management of those symptoms. And initially, the goal is to initiate it as soon as possible. Research shows that patients have better outcomes when the process is initiated sooner. Think about discharge. We often say discharge is started when? On admission. So once they get that diagnosis or once it's determined that this individual will have less than 6 months to live, we want to go ahead and initiate the process. You want to honor their wishes and the preferences of families. What could be some common wishes for the patient or the family? May get to pass at home is a good example. What would be another example? A religious preference. What did you say, Gregory?
DNR.
DNR, right. So we're going to talk about some of that next week as we look at the content. Your PowerPoint is already uploaded in Teams and it's in modules for you to start reviewing the information. Assisting patients to identify goals of care. They may have some goals that they want to take place during this process. Promoting communication among the patient, the family, and the members of the interdisciplinary team. Meaning we need everybody to be working in the same manner toward the same goal. So great communication is going to be needed. Promoting continuity of care for transitions to the home setting. You know, if this individual is in the hospital, we may be transitioning to home, or we may be transitioning into a nursing home, for example. So wherever that transition may be, we just need to communicate and communicate effectively. The National Consensus Project for Quality Palliative Care is known as NCP. NCP plays a major role in moving palliative care upstream, just getting it on board, getting everybody on board. They're going to publish clinical practice guidelines in terms of palliative care. They're going to promote things like high quality care. reduce variations in new and existing programs, and they're going to encourage continuity of care across the setting, whether you're in the hospital, whether you're in the nursing home, or whether you're having this care at home. And they're going to facilitate collaborative partnership, meaning who all needs to be involved, making sure that they're involved in this individual's care. They're going to promote recognition, make sure that there are stable reimbursement structures and accreditation initiatives throughout the National Quality Forum, known as NFQ, as well as other projects. If you look in your book on page 483, you'll see the 8 domains of palliative care. So let's take a brief look at page 483 and look at those domains of quality of palliative care. I'm not going to read over those, but I do encourage you just to kind of review them to know what those goals are in terms of offering and providing palliative care. Can you guys see those? On page 483. So when we look at the theoretical links continue, there are clinical practice guidelines. Like guidelines for you as a nurse, there's guidelines for palliative care. The accreditation or certification will come from the Joint Commission. I think we're all familiar with Joint Commission, right? So there are guidelines that must be in place for palliative care. There are educational framework, and that's Hospice and Palliative Care Nurses Association. So just like you have guidelines for practice, they have guidelines for palliative care for these clients. The context to nursing and healthcare, the impact of chronic disease is one of those things that we're going to talk about. For example, the leading causes of death in the United States. We're going to mention those 10 leading causes. 7 of the 10 Americans can expect to live with their diseases several years before dying. Why is that so? What has happened over the last few years? Or what's happening every day? What?
Advances in medical treatment.
Advances in medical treatment and technology. For example, back in the olden days, did we have maybe MRIs or ultrasounds? We're seeing the advances in medical treatment as well as technology. Advancing age of 8 million baby boomers. What's going to happen with these baby boomers? What's coming up for them? Or what are they getting ready to go through? Or where are they at in life? They're able to get what? Qualify for Medicare. These baby boomers are what? Headed out of the workforce, and who's coming in? It's scary. It's scary. So the leading causes of death in the United States, and I'm just going to mention a few, but again, I think we're going to cover these next week. Your book lists the top 10. But cardiovascular disease, cancer, cerebral vascular disease, chronic obstructive lung disease, unintended injuries, as well as dementia. There's an increased nursing workforce is needed to keep up with the demand. What do we know right now? What's going on in the clinical facilities you're going to? Nursing shortage. I don't know about you guys, but last week I made assignments and I was told we got 20 in ER waiting on the room to come up. So that was last weekend. What's going on in your area for those of you in clinical practice? Are they holding patients in ER? Can't send them to the floors because they don't have nurses. They have beds, but they don't have the staff to work. I will tell you that we also saw at my clinical facility no full-time staffers. Everybody was a contract staff nurse. No full-time employees. So I think this statement, the last statement, increase for nursing workforce is needed. And not only that, what's going on in education? What's going to be happening to a lot of your instructors like Dr. Norman in the next few years? They're out of here. They're coming up for retirement. And guess what? New nurse educators, are we having a hard time recruiting them? Why do you all think we're having a hard time? Nobody wants to take that half salary pay cut from the floor to the classroom. Would you all take it? Okay, so we gotta love what we do, right? I think I enjoy it. It is not for the money, okay? Let me just say that. I'm going to repeat that. It is not for the money. No, ma'am. It is not for the money. So, again, I can't put enough emphasis. We need the nursing workforce. We need educators to produce nursing students, to produce graduates to be at the bedside. And what other things are we impacted by now? Who wants to be at the bedside? What is everybody doing? They're going back to be a practitioner. We don't have the nursing staff at the bedside because now what? There's an open for everybody wanting to be a what? Nurse practitioner. The market is flooded and they can't find a job. Are y'all up to date with that? Have you heard about that? Yeah. So again, it's going to be a team-based approach. The plan of care is based first on the patients. Again, the family is included, and we got to have realistic expectations and goals. The family serves as a member of the team. I cannot put enough emphasis on the family. Here, the family plays a role because if this patient is going home, who are they going home with? Family. So the family is a team player, okay? In the context of nursing, there are some ties, and these ties can be found in your book on page 481. This is what the team is going to look like. So when we speak of the team is going to include what? A spirituality component, and who might that be? The chaplain, the preacher, the pastor, right? The bishop, the nurse, that's you and I. We mentioned earlier who else was a part of the team? Social services. What about medicine? Is medicine going to be a part of the team? I'm going to say that's going to be a key player I want on my team, right? What else? Psychological support, care coordination, and case management. Do we need that? Why do we need that? Who's going to help us get that equipment we need at home, right? Those supplies we need. What about rehabilitation services? Is that important? Rehab is key as well. Do we need those therapists? PT, OT, ST, do we need them? Therapists? Pharmacists. Why do we need the pharmacists?
To make sure there are no interactions between the medications.
And drug-to-drug interactions or compounding meds. Let's say you get to a point where you can't physically take meds. We might need those meds to be compounded into a sublingual or into a suppository, right? We need somebody who can do that. And pharmacists as well as volunteers. Do y'all think about ever giving back to your profession of nursing? Who's volunteering in here this semester? No. Oh, come on. Just volunteering to help. How many of you volunteered to help somebody out that was deaf and dying? Who took a shift? Who did night shift? Who went in and stayed an extra hour? I'm going to get grandmama tonight. It might not have even been your family member. It could have been the person you were dating. He's like, okay, you got to do Granny's bath tonight. I'm not a family member. I'm assigned to Granny. Yes, it takes the whole team, right? Because is there something called care provider burnout? Yes. Yes, and it is what? Real. If you haven't been there, trust me, it's worse than a job. I don't know nobody that's volunteering to say, I'll do that. It's a job. So, primary palliative care providers, they have the working knowledge on the issues surrounding the patient with the serious condition. And this information is coming from your book on page 482. And then there are specialty palliative care providers. They have the expert knowledge in all the aspects of palliative care. They're going to be talking about or looking at the main goals, like treating the pain, treating the symptoms, the advanced portion of the illness, as well as communication. When we look at the Institute of Medicine, they released a report in 2014 saying or stating that palliative care should be covered by all insurers. What do you think about that statement? I'm on board for it. If it's my family member, don't you want that insurance to take care of them and it's not a financial burden on you or the family? Yes. They also released a statement saying that standards of care should be evidence-based and continuously updated. What are we practicing now? Are we practicing evidence-based nursing? Who could give me one example of something we're doing evidence-based? Anybody? Aseptic technique. I got a good one. What about the dorsoventral Are we teaching y'all to give that injection there anymore? Evidence-based practice shows us that what can we do when we're giving that injection back there? Damage that sciatic nerve. But in some of your rural small clinics, you walk in there, what they gonna give you? A dorsogluteal injection. Are they up to evidence-based practice? Probably not. But that's what the goal for IOM is. In terms of palliative care, it should be evidence-based practice, and it should be updated regularly. When we look at the ANA, and that is the American Nurses Association, and HPNA, Hospice and Palliative Care Nurses Association, they had a plan for action. The document emphasized that there is an interdisciplinary model of clinical practice. They wanted to reflect the patient's wishes as well as the patient's preferences. So who is at the center in this model? The patient. The document was created indicating that there should be collaborative evidence-based plans of care based on the patient's wishes. And there is a mandate that any nurse in this area have primary palliative care skills. So can I just jump out and say, I want to be a palliative care nurse? No, they're mandating that you do what? Get training and your skill, you're competent in how to provide palliative care to this patient. So a nurse like Lisa, for example, I'm making up this name. If Lisa is considering going on to hospice or being a palliative care nurse, what would be a good idea for Lisa to do? What's the first thing Lisa needs to do?
Volunteer.
Know what's expected? I hear volunteer.
Volunteer to watch somebody.
Volunteer to watch somebody. What about examine her own feelings and beliefs? Why would that be important? Non-judgmental. What else? Non-biased. That's like the nurse, and we had this discussion in my clinical group Saturday. Should you be going to the detox floor to take care of the detox patients if you feel in some kind of way because your family member was killed in a motor vehicle accident by somebody who was intoxicated? Do you need to be working that floor? So the same example goes for palliative care. You need to identify your own feelings and beliefs before you jump into palliative care. And not only just for palliative care, you guys are going to leave here and you're going to work in various areas. And the first thing you need to do is a self-check. If you're not feeling it, if you know you're feeling funny about it, are you going to provide the best care that patient needs? No. You really need to think about it. I'll use myself as an example. I was a graduate from this program, and I signed on at Two Road Infirmary to work oncology. Me and a best friend, we're going to do what we're going to do every weekend, high-paying job. Hey, I didn't have a problem with it, and neither did she. But as time went on, I was offered a position here in labor and delivery. I had no biases, but I thought about it, and I said, you know what, I'm going from one end of the spectrum to the other. And when I thought about it, what meant most to me was bringing someone in the world instead of witnessing someone going out. Kind of odd example. Not that I was biased, I had signed up, but hey, opportunity approached, and I took advantage of it. My friend, she kept on, she went on to New Orleans. Two Row Infirmary, did it for up until Katrina hit. So you need to examine your own biases in whichever direction you go once you leave this program. Interrelated concepts, they're listed there. I'm not going to read over them. But the concepts we're going to focus on is only two. And what were those exemplars? Palliative care and death and dying. All of this ties into it. Could healthcare quality tie into palliative care, death and dying, grief and loss? Yes. What about caregiving? Is there a need? Can we see sleep, nutrition falling into this? All of these that are listed goes along with grief and loss, okay? We're just not going to emphasize them as much, but we're going to talk about them when we go over your lecture on Thursday. Common palliative care services is mentioned in your book on page 482. So if you look on page 482, briefly, box 51.1, there's a box that goes over common palliative care services. What is respite service? Who can tell me what that one is? I like that one. Where the family members get a break. Did y'all know that something like that existed? There is an agency on aging that's in Newton, Mississippi that provides palliative care to come in and give the family member a break. I think that's just like the best thing that happened. It's like the reinvention of sliced bread. It's just good. Because as I mentioned earlier, what happens to that individual? Is it like a full-time job? Does it end? Do you tag in and tag out? You're lucky if you can get family members to what? Buy in and come in and do what they're supposed to do. How challenging is that? I imagine it could be very cumbersome. What do you all think? Especially if you got this generation who want to live their life. You know, I'm living my life. It's about me.
Or if there's the other family members are scared of said patient.
Oh my goodness. Yeah, scared.
Well, my example, my son had a tracheostomy. He was on a ventilator. Nobody would help me watch him, except for the three registered nurses that came to my house at night so I could sleep.
It can be really tough. Featured exemplars, again, palliative care, death and dying. There's a page 484 in your book that reviews the examples of palliative care. So 484 in your book. I see people packing up. Quick questions, maybe? Question number 1. I'm just saying, this is my time, 25 minutes. Any takers? Any takers? Any guesses? Biomedical. We didn't talk about biomedical, so take a good guess. Which one? Number 1 is correct. Very good. Let's move on. Question number 2. Better get it right. Say it loud. Say it proud. 4. Number 4 is correct. Very good. Question number 3. Take your time. This is very important.
2.
The best decision. Say it again. That's you. That's you. You're the important one, okay? I'm going to press in on this 28-minute lecture.